Hello, members and guests of ICS. Thank you for allowing us to present our data. My name is Rahul Patel, and I'm a fourth-year medical student and interested in urology. I worked on this project with Dr. Zimmern at Southwestern, who's treated women with recurrent urinary tract infections for a long time now. We decided to study whether or not bacterial motility influences the extent of bladder wall involvement in women with recurrent urinary tract infections. I have no disclosures. For a while, we have been wondering why in women with recurrent urinary tract infections, some exhibit cystitis just at their trigone, also called trigonitis, whereas in others it spreads beyond the trigone. Our prior electrofulguration outcome studies have shown that those with higher stages of bladder wall involvement fare worse. Because animal studies have shown that bacterial motility has been implicated as a potential virulence factor, we decided to study this in humans. Therefore, the objective of our study was to compare motile and non-motile bacteria from urinary cultures of women with recurrent urinary tract infections before electrofulguration at different stages of bladder wall involvement. This was an IRB-approved retrospective review conducted between 2006 and 2020 of women with antibiotic recalcitrant recurrent urinary tract infections, defined as 3 or more in 1 year, who underwent electrofulguration for cystitis. If they did not have pre-fulguration cultures, unretrievable or negative cultures, or catheter-related urinary tract infections such as CIC or indwelling, they were excluded from the study. We utilized pre-fulguration office cystoscopy in order to characterize the different stages of cystitis based upon the amount of bladder surface involvement. As seen on the figure on the right, there are 4 stages. Stage 1 is inflammation of just the trigone, also called trigonitis. Stage 2 is inflammation of the trigone and the bladder base. Stage 3 is inflammation of the trigone, bladder base, and lateral walls. And stage 4 involves the entire bladder, also termed pancystitis. We also collected demographics and positive urine cultures prior to fulguration. We categorized urinary strains based off the motility properties into either motile or non-motile. We next compared these urinary strains amongst each different stage of bladder wall involvement. Here are 2 example images. On the left is a cystoscopy image of a patient with stage 1 cystitis, also called trigonitis. Notice how there are no lesions observed beyond the intraureteric ridge. On the right is an image of cystitis cystica with lesions extending to the bladder base. This would be considered stage 2 cystitis. In total, we had 139 women with a median age of 67 and majority being Caucasian. Stage 1 patients were significantly younger, and stage 4 patients were significantly older, had higher parity, 3 versus 2, and were less sexually active. Regarding motility properties, we observed no difference in overall motility. We also observed that E. coli was the most predominant strain amongst all 4 stages. Excluding E. coli, we noticed that patients with stage 4 cystitis had a preponderance of more severe motile bacteria, specifically Proteus, Pseudomonas, Enterobacter, and Citrobacter. Also, we observed that the non-motile bacteria Klebsiella was observed at higher stages such as stage 3 and stage 4. In conclusion, what we learned is that women with recurrent urinary tract infections at higher stages of cystitis have more unique types of motile and non-motile bacterial urinary strains compared to those with lower stages, and that further study into bacterial motility properties amongst each stage would be beneficial. Thank you for your time.